Hi everyone, I'm Dr. Pranitha, consultant neonatologist in King's Cuddles, Kondapur. Today I'm going to discuss about screening of developmental dysplasia of hips in neonates. So DDH ranges from a wide spectrum. It can be hip dysplasia to subluxation to dislocation. So why is screening of DDH in neonates is so important is if the baby is screened at birth and if we diagnose DDH at birth, we can manage it conservatively with Pavlik harness. But when detected at a later age, it leads to limb arthritis and need for surgical intervention. The most common risk factors for DDH are firstborn female child, can remember by F and F. Apart from that, when DDH is diagnosed antenatally in the second trimester, it can be because of some genetic problems or some problems with musculoskeletal problems like arthrogryposis congenita, or it can be most commonly associated with Wryneck or torticollis. It is seen in some genetic syndromes like myelodysplasia, Larsen syndrome, which is associated with dysmorphism, short fingers, congenital dislocation of hips, congenital dislocation of knees, and congenital dislocation of elbows, along with spinal defects. When detected in third trimester, it is most commonly because of mechanical reasons. Say there is no space for the baby to move, either because of decreased amniotic fluid, or it can be because of a large LGA baby, or it can be because of breech presentation. Sometimes DDH may not be present at birth, but it can occur postnatally. That is usually seen because of improper swaddling. So swaddling seen in Asian and African countries is appropriate where there is good range of movements for the hips and legs. But swaddling which is seen in American and European countries restricts the movement of limbs, which can predispose the child to postnatally acquired DDH. So among the many risk factors, the four most important ones being breech presentation, family history of DDH, presence of clinical signs of DDH, and swaddling. DDH can be either because of syndromic or teratologic causes, like we have just discussed. It is associated with arthrogryposis, Larsen syndrome, myelodysplasia, or it can be non-syndromic because of familial causes, LGA babies, breech presentation, and oligohydramnios. How do we diagnose? So we need to examine baby immediately at birth, before discharge, and subsequently in all the following well baby visits. And also at vaccine visits at 6 weeks, 10 weeks, 14 weeks, 6 months, 7 months, 9 months, and 1 year of age. So the most important clinical signs which are elicitable at birth are Barlow's test and Ortolani's test. So within the first 3 months, these two signs are the most important signs. Between 3 to 6 months, limited hip abduction and Galeazzi sign are the most important signs. And above 6 months, along with limited hip abduction and Galeazzi sign, if the child is walking, we can also see limp, Trendelenburg sign positive, and the child can be walking with toes on the affected side. So coming to Ortolani's test, which is positive, where the dislocated hip can be relocated. That is OR. So in Ortolani sign, we place the baby supine in the supine position. Hips are placed at 90 degrees, and we try to apply pressure with the thumb on the medial side and the other fingers on the greater trochanter, and abduction is done. And this leads to the clunk being produced because the dislocated hips are relocated back. So this is Ortolani sign positive. And coming to Barlow sign, in the similar position, we try to apply positive pressure with the adduction medially. And Barlow's sign tests the dislocation of hips, that is BD. So Baharlow, we can remember by Baharlow, which means the hips which are reduced, but they can be dislocated. The sign which is most commonly seen above 3 months is the limited hip abduction. So normally hips can be abducted at up to 80 to 90 degrees. If there is difficulty in adduction, in like there is difference of adduction at least 20 degrees between two hips, then it is positive. In case of bilateral hip dislocation, this can be falsely negative. In this case, if we are not able to abduct beyond 60 degrees, then it means it is a positive sign. The other sign which can be seen as asymmetric creases on the thigh. So sometimes this can be a falsely positive sign, and it can be seen in certain normal newborn infants also. Galeazzi sign is another sign which is seen elicitable above 3 months. Here the baby is placed supine, the knees are placed folded with hip flexion. So we can see that there is asymmetry between the two knees. This is because of limb-leg discrepancy. In case of bilateral hip dislocations, there is absence of Galeazzi sign and there is absence of limited hip abduction. But these children can present with hyperlordosis in later age group along with limp, waddling gait and Trendelenburg sign positive. So when the Barlow sign is positive at birth, we can still wait till 6 weeks because sometimes it can be falsely present because of hip immaturity. So we usually screen these infants again at 6 weeks with ultrasound scan. But in case if there is a possibility of loss to follow-up, we can screen them much earlier also. And if the ultrasound is positive, we straight away refer them to orthopedics. But in case the ultrasound at this point is normal, still we need to keep these babies in surveillance and screen them again at 6 months with chest X-ray. So coming to investigations. So the indications for imaging being positive signs, that is Barlow and Otoloni test positive. If there is one or more risk factors, the 4 more important risk factors we mentioned previously, and babies with inconclusive or uncertain clinical examination. So the choice of investigations at birth beyond 6 weeks is usually ultrasound. In between 6 to 14 weeks, we can do ultrasound at the earliest if there is positive clinical signs. But in case if there is non-availability of ultrasound, we can go ahead with X-rays. Between 3 to 6 months, again, we can do either an immediate ultrasound or X-ray. And beyond 6 months, we usually do X-rays. So this is for Indian setting where ultrasound may not be available at all the units. So in that case, we can go ahead with X-rays little earlier. According to AAP recommendations, in less than 4 months, we usually go ahead with ultrasound scanning. But beyond 4 months, we go ahead with X-rays. So coming to management, this is dependent upon the age. So till 6 months, what we have to do is we need to counsel the parents regarding correct swaddling practices. So the baby shouldn't be swaddled too tightly, restricting the movements. The swaddling should be simple and easy such that which facilitates the movements of the lower limbs. Double diapering and triple diapering, which was earlier recommended, is no longer used. And Pavlik's harness is the most commonly used splintage in the babies less than 6 months. So this consists of a shoulder strap, which is used for adjusting the flexion of the hips. And there are abduction straps, which are used to facilitate the abduction. So excessive flexion should be avoided because it can lead to nerve palsies, and excessive abduction should also be avoided because it can lead to avascular necrosis of femur. So if the hips are stable, Pavlik harness is almost 100% successful. But in case of dislocatable hips, that is Barlow positive hips, it is positive, like it is successful in 90% of cases. In Otoloni positive hips, that is the hips are dislocated but they can be reduced, Pavlik harness is successful in 60 to 90% of cases. But if the hips are irreducible, it can be successful only in 40% of cases. So Pavlik harness is usually used for 4 weeks. It is not recommended beyond 4 weeks of age because it can again lead to avascular necrosis of femur. Beyond 4 weeks, if there is no success with Pavlik harness, we go ahead again with closed reduction. So the child needs to be in follow-up with the orthopedician. So this is another splinting which is used called Frega splint. This is a mattress kind of thing. It is usually quite easily administered. And when compared with Pavlik harness, there is no difference in radiology findings at 6 years. Failure rates are 12% with Pavlik harness and 10% with Frega splint. And the rates of avascular necrosis is 6% with Pavlik harness and 7% with Frega splint. So this is von Rosen splint, which can again be used in babies less than 6 months of age. And this is Elfel splint, which is an abduction brace, which can also be used in babies less than 6 months of age. But among all these four, even now, Pavlik harness is the most commonly used splint for babies. So beyond 6 months, when the baby is very active, it is difficult to place the baby in the harness. At this age, we usually do closed reduction under general anesthesia. So the closed reduction should be done considering the safe zone of abduction for babies. And after the closed reduction, baby is maintained in a hip spica cast. So this spica cast is maintained at least for 6 to 12 weeks. So after 12 weeks, the plaster cast is removed. And at this point, if the abduction is if the hip dislocation is successful, then we use abduction orthosis. But in case there is failure of reduction of the hips, then this is an indication for open surgery. So beyond 2 years, we should go ahead with the open reduction. And in case if there is also problem with the femur or acetabulum, we usually do femoral shortening osteotomy or acetabular reconstruction. And following which, again, the baby is immobilized for 6 to 12 weeks in hip spica. So between 2 to 8 years, again, this is the most commonly used management. But beyond 8 years, if it is bilateral hip dislocation, we do not do anything. We just leave it. And if it is just unilateral dislocation, we can do a surgery, but with guarded prognosis. So when the baby presents at birth, we usually screen for 4 risk factors. That is presence of breech presentation. Is there any family history? Any improper swaddling practices? And any history of hip instability in any of the clinical examination. If one or more of the risk factors are present, then we go ahead with the ultrasound at 6 weeks. And the clinical examination which are usually used is Barlow's and Ortolani's test in less than 14 weeks. Between 14 weeks to 6 months, it is limited hip abduction, Galeazzi sign, and limb length discrepancy. And beyond 6 months, it is limited hip abduction, Galeazzi sign, limb length discrepancy, along with Trendelenburg sign positive or limpy gait. And in some cases, we can also see lumbar hyperlordosis. So if there is any of the presence of the clinical signs present, if the baby is less than 6 weeks, we wait for the ultrasound. But if there is concerns regarding follow-up, we can do an urgent ultrasound. Beyond 6 weeks, we usually do ultrasound. And if the ultrasound is positive, we straight away refer to the orthopedician. But in case ultrasound is normal at this point, we again do the test for babies at every visit and return to routine hip surveillance at 6 months with a chest X-ray. So the choice of investigations in less than 14 weeks in Indian setting is ultrasound first. Between 14 weeks to 6 months, again, ultrasound is preferred. But beyond 4 months, we can go ahead with X-rays. So this guidelines is taken from this. So to summarize, we have discussed about routine hip examination timings. What are the reliable clinical signs of DDH? What are the risk factors for DDH and the timing of imaging? And early diagnosis is important because it helps us in managing the baby conservatively, and the outcomes are favorable with lesser chances of limp and lesser chances of osteoarthritis in adults. Thank you.